I'll back up just a little bit and talk about how I came to learn about a ketogenic diet. So here's my disclosure. I started practice in 2000, and probably right around that time was when this book called The New Atkins for a New You came around, or The New Atkins Revolution. And I had all these staff members asking me about it, and I was your classic conventional medical doctor going, oh my God, that'll be terrible for you. Like, why are you doing this? But I had so many questions. I said, you know what? I need to read this book. I need to read it. I need to understand it. I was not obese by any means, but I'd had 2 children, trying to get rid of that excess weight. And I was thinking, well, I'm not as happy with myself as I could be. I should read it. And the science, the biology, it just all made sense, right? So I went ahead and I went on the diet myself, found great results. And as many of you know, cancers are often related to obesity. So I had always kind of talked to patients about using it as a weight loss diet. But it wasn't until probably about 4 years ago, reading Travis Christofferson's Tripping Over the Truth and being familiar with Dr. Seyfried's work and really understanding cancer as a metabolic disease, where I said, oh my gosh, this is not about weight. This is about metabolic health. And to share one quick story, I have a patient who's been in ketosis. She tests her ketones, and she's done it for 2+ years, and she hasn't lost any weight, and she's still considered BMI of obese. She doesn't, look obese, but she's heavier, but she has reversed every single metabolic marker that I can test. So again, it's not about weight loss, although that's what a lot of people get into it to get started with, but how many people know a thin person with cancer or with diabetes or with heart disease? So it's not about weight, it's about health. Oh, so I made a lot of formatting edits, but apparently they did not make it through. So I'm very sorry. I just spent 5 minutes doing all of that, so we're going to be off on a lot of slides. But the bottom line is every year they add more cancers that are associated with obesity. But is it really about obesity, or is it about the same metabolic drivers of obesity? So what is a metabolic disease? To be put simply, it's just any diseases that come about that disrupt the more normal metabolism. So when we eat food, our body needs to convert that food to energy. And if we are not doing that properly on a cellular level, we have some degree of metabolic dysfunction. And if you want to read the more scientific terms, you can read them at the bottom. But the bottom line is how do we metabolize food to energy? So some of you may have seen this slide before, but basically what happens when we continue to stack damage on top of damage, we are actually harming our mitochondria. These are our powerhouse cells. These are the little organelles in our cells which actually convert food to energy. So when we damage them far enough, they become abnormal. They don't behave normally. So this is what we call a GBM, or a glioblastoma multiforme, which is a very aggressive brain tumor compared to a normal mitochondria. So this is kind of a cartoon of a cell. You don't have to know all of this. I'm not going to go through it. But let me get my pointer out here. This is the mitochondria here, kind of showing all the different processes. Main one, electron transport chain. But this is kind of the area where we're burning fat. And when we damage that, what do we have? The glycolysis. So that turns into kind of our most common metabolic process when we're not able to functionally burn fat well. And interestingly, we talked about insulin resistance and glucose, but the reason why we need insulin for glucose, shuttling, is because these GLUT receptors are inside the cell, and it's not until insulin kind of tells the cell that there's glucose out there, you need to let it in, that's what then brings this receptor or this transporter to the surface and allows that glucose to come into the cell. So if this isn't working, now glucose is just staying out in the bloodstream and not getting into those cells. And interestingly, when we look at, and this is from 1990, this is not new, but they looked at the insulin receptor content in normal breast tissue versus fibroadenomatous breast tissue or fibrocystic disease versus breast cancer tissue. And you can see how those breast cancer cells have significantly upregulated their insulin receptors so that they can draw more sugar into the cells, and cancer cells have been shown to maybe use 100 to 200 times the amount of glucose than our normal cells. And we see this when we're in clinic measuring tumors. When we're trying to get an estimate of the degree of disease in a patient, we might order a PET scan, and a PET scan is radioactive labeled glucose. We inject a patient with glucose, and that radioactive labeled glucose then is able to be captured in a scan. So this, sorry, I've got to do the double take. So this is a pelvis of a patient, and these are some bowel loops. This is the bottom of the uterus, top of the cervix. These are the hip bones, and this is the tailbone. And what we see is that when we overlay the glucose projection on the CT scan, that we get this area of uptake that we don't see on a CT scan, but we know that that area has significantly more metabolic cancer cells. So we use that to help us. It's not perfect. You have to have so many cells there. So if you have a clean PET scan, it doesn't necessarily mean you don't have cancer there, but when you do see this, you know you have significant disease there. Now, we'll go back just a hair to say, how did we get into this mess? But I know that you guys already know this. But obviously, when we started to see this slow rise in disease risk, we said, oh my God, we got to do something, right? And unfortunately, we came up with this: fat makes people fat, and fat causes heart attacks. And so we put in these national dietary guidelines without a lot of scientific evidence. And what we found, obviously, was that there was a significant skyrocketing of obesity. And why? Well, we were told to eat all of these foods on the bottom of the pyramid, replace those fats with carbohydrate, replace fatty meats maybe with plant proteins, and what happened? Well, we know what blood sugar responses are to different micro or macronutrients. When we eat carbohydrates, we get a very sharp spike in blood sugar. When we eat fats, we get a very low or no uptake or increase in blood sugar. So when we're eating things that are a combination of fat and protein, like meat, eggs, dairy, we're getting somewhere in between that fat and protein level. But when we're eating things like beans and legumes, legumes and grains, we're getting something in the protein carbohydrate combination. So again, much higher. And so what happened to our blood sugars? Instead of staying low, we continue to get multiple spikes. So this is just different responses in blood sugar to the same type of food, but in different degrees of metabolic dysfunction. So in a normal, quote unquote, healthy individual, they might have just a small rise in glucose, and insulin super sensitive, they're just shuttling that sugar away, where somebody who's maybe borderline pre-diabetic, they're getting much higher spikes, and then they get that dip, right? Because the glucose or the insulin remains elevated, and that's that hangry, your glucose is falling, you need to get something into you. And the diabetics, they never come down, right? They're way up there. Now they need exogenous insulin to help bring those numbers down. But this was a study done looking at normal, quote unquote, so these are healthy, non-diabetic individuals where they were all fed the same thing. And in this example, it was actually a bagel with cream cheese. So we know a bagel is high carbohydrate, but you add some fat to it, maybe you have less of a blood sugar response. But what we can see is that the yellow curves are probably relatively normal, but these blue and brown curves are significantly abnormal. But these are people who we in the medical establishment said are healthy. And if you don't know what's happening, you don't know what's happening, right? So Kraft, some of you may be familiar with this. This is looking at an insulin curve, right? So now we're giving patients, or Dr. Kraft gave 14,000 patients, non-diabetic, so these were considered healthy people, gave them a shot of glucose, right? Drink this sugary drink. But then he measured insulin at 1, 2, 3, 4, and 5 hours. And what he found was that really only the green, the number 1 response curve, was a normal metabolic response to sugar. And so he calculated out that only 20% of patients that we think are healthy are actually metabolically healthy. And when this study was just published in 2018, so 8,700 patients, men and women over the age of 20, they looked for signs of metabolic syndrome. So they looked at waist circumference, fasting glucose, blood pressure, hemoglobin A1C, triglycerides, and HDL, and those not taking any medications. So if you're taking any medications or fit any one of those elevated categories, then you were considered metabolically unhealthy. And what they found was that only 12% of all American adults were considered metabolically healthy. So down from the 20% that Dr. Kraft found. And if you were obese, 0.5% metabolically healthy. If you were overweight, only 8%. But back to normal weight individuals. We think, oh, you look great, you're healthy. 31% were metabolically healthy, so 70% were not considered metabolically healthy when you were normal weight. So, what have these done to impact cancer? So we're going to go through some studies. I've tried to really simplify it, so even though I'm referencing everything and the references are usually at the bottom of the page, we'll go through some science to say, is this what we should be doing for cancer? Because, right, low fat, high healthy grains, vegetables, and fruits, that's the way we should all be eating, and that's going to help you with cancer. But let's look at the data. So again, sorry about the formatting. 62,000 postmenopausal women, this was a French study, and they were followed for 9 years. And what they found was that rapidly absorbed carbohydrates were actually associated with postmenopausal breast cancer in overweight women and women with large waist circumferences, and that there was a direct association between carbohydrate intake, glycemic load, and estrogen receptor negative breast cancer, so a more aggressive breast cancer that we have. And a direct association just means that the more you ate, the more likely you were to have that. Again, 2,500 Italian women with breast cancer. So these are patients with breast cancer, and they matched them to case control. So they tried to find women who didn't have breast cancer and then look at the difference between them. And what they found was that there was an increase in having breast cancer associated with the available carbohydrate, and it was predominantly starches in this group. And there was a decrease in breast cancer risk with increasing fatty acids. So fat, good; carbohydrate, bad. And there was so we also often hear saturated fat is really the bad fat, right? That monounsaturated fats are great. But when they looked at this, there was no increased risk with increasing saturated fat. There was no increased risk with increasing protein, and there was no improvement with increasing fiber. So fiber didn't actually, there was a null, no increase or decrease with those. When we looked at 150 postmenopausal women with breast cancer, they found that those patients with later pathologic stage, so instead of having an early stage, stage 1, they were more likely to have a stage 2, 3, or 4 if they were obese, if they were centrally obese, so middle fat, belly fat, if they had high glucose levels, and if they had high insulin levels. 51% of those later stage patients had metabolic syndrome compared to only 12% of the early stage patients, and patients with lymph node positive disease were significantly more likely to have high insulin levels and have metabolic syndrome compared to those patients with node negative disease. This was a group of patients with breast cancer, and they compared them again to control patients. So they looked at a similar group of patients, and they matched them for age, for BMI, and for lipid levels, trying to rule out any differences based on those things. And what they found was that when they looked at fasting insulin, on average they were normal, but you can see the control group was much lower than the breast cancer group, and that was statistically significant. Fasting insulin, same thing. So when you go to the lab and you look at normal ranges, I'm going to tell you normal is not optimal. Normal is just what do most people walk in the door. And what did we just learn? Almost everybody has metabolic dysfunction, right? So we don't want normal, we want optimal. And in this group, the control group had a fasting insulin of 6.8 versus the breast cancer group, which was 10. That was statistically significant. Hemoglobin A1C, and this is why I'm not a huge fan of hemoglobin A1C. I much rather look at insulin, which I think goes way haywire prior to sugars, prior to hemoglobin A1C. But that was not statistically significant, and they were in the mid-5s. HOMA-IR is an insulin resistance calculation. It's not perfect, but it's pretty decent. And that showed significant elevation as well. So, and this is basically a calculation of fasting insulin and fasting glucose. So it gives us some degree of information as to the insulin resistance of that patient. So when we look at fasting insulin, this is Ferroni's paper, and this was just looking at all cancer patients and looking at their pre-treatment insulin levels to say, based on their pre-treatment insulin levels, how did they do? And so they didn't do any kind of intervention. It was kind of a retrospective, like, here's all these people, this is how they did, let's go back and look at what their pre-treatment insulin levels. And what always I bring up, because I think this is European or French, I think, and the other one that I'll show you is from Canada, and I'm like, how do they have fasting insulins on everybody? I even tell patients to go get fasting insulins because no one's ever looked in their entire medical career, of seeing doctors and being put on medicines, not pre-diabetics, not diabetics, no one checks fasting insulin. So I'm impressed always that these guys even had it to pull from charts. But you can see that when you were a stage 1, you were more likely to have a lower fasting insulin than if you were a stage 4. Those numbers just skyrocket as we go into higher stages. And they chose 13 as a cutoff, just saying, okay, if people had lower than 13, how did they do compared to if you had a fasting insulin above 13? Now, we might just say, well, that's just because those patients were more likely to have a higher stage. And that is true. So I can't say that it may not just be related to stage, but I do think that fasting insulin is still an important marker. And what you can see is this is for all patients, and the top line is those patients who had fasting insulins less than 13. This is for estrogen and progesterone receptor positive patients. So those are patients who typically have what we consider to be a more favorable breast cancer. And you can see they do even better with a fasting insulin less than 13, and even worse with a fasting insulin above 13. Then when we look at all patients, HER2 positive patients similar, or HER2 negative. Then they divided it out between postmenopausal and premenopausal. And you can see in postmenopausal patients with the low insulin levels, they do pretty well, but worse when they have higher insulin levels. Same thing goes for premenopausal, sorry. So again, no matter how we slice and dice it, fasting insulin seems to impact outcomes. This next paper, I think this is my Goodwin paper, 512 women. They all had what we considered kind of earlier stage. They had to have a T1, which is a very small tumor, to a T3, which is actually a bigger tumor. And they had to have up to 4 positive lymph nodes. So anything more than 4 positive nodes, they weren't included. Stage 4s were not included. But what they found is that, and they looked for everything. So they looked for body size and fasting blood markers, whether it was cholesterol or sugars or insulin. They looked at a lot of different markers, but they came down to high levels of fasting insulin significantly was associated with higher T stages, so bigger tumor size, more likely to be node positive versus node negative, higher tumor grade. When we look at cancers under a microscope, we consider them either well differentiated, meaning they look more like normal breast cells or regular tissue cells, all the way up to grade 3, which is more aggressive, higher dividing cancer cells. And then what they also found was that insulin level was strongly associated with BMI, and what got cut off down here is that women with high BMI were twice as likely to develop metastases. Again, was it BMI or was it something else? And this is looking at hazards ratios, and hazards ratios are just the likelihood of developing. So if we start with 1 being kind of our baseline, and then how much more likely are you to have some issues. So this first graph is, or bar graph, is on recurrence, and you can see that if you had a very low, and this is low, does everybody here know what their fasting insulin level is? Does anybody know? Oh, I have a chore for you later, but okay. So this is actually pretty low, and you saw how long I've been eating a low-carb or ketogenic diet, and I will tell you that I've been continuously in ketosis probably for 4 years or so, and I was still in the 5s. And then I made some more significant changes, and I really, because I like to study labs, but it took me a while to really tweak and work on what I was doing to get myself into the 3.4 range. Hopefully it's still going down, we'll see, because I'm due for my next batch. But these are really low. Like if you go into the lab and you say what's the normal range, most normal ranges are roughly 2.5 to 25. 25 is considered normal. So I'm just telling you right now, normal is not optimal. So anyway, so hazards ratio goes up almost 3.5 times when you just bump it up a little bit. And the same thing with overall survival. Survival got significantly worse the higher that fasting insulin was. This was a great study looking at insulin-like growth factor 1. So that's just a sister receptor to insulin, and they often they look similar, meaning if one is high, the other one may also be high. But interestingly, some cancer cells have insulin-like growth factor receptors as well as insulin receptors. And what they found is it's not necessarily negative, but low insulin-like growth factor, I think negative was considered less than 10%, and positive was considered greater than 10% or something in that ballpark. And this is, again, looking at hazards ratio, so the increased risk compared to 1. So if we consider IGF-1 receptors negative, the IGF-1 positive patients do a bit worse. In the same group of patients, they looked at carbohydrate intake after diagnosis. So this group of patients, if they decrease their carbohydrates after diagnosis, that's where they considered the hazard ratio was 1. If they did not decrease their carbohydrates or increase their carbohydrates, because maybe they shifted to that low-fat, high-fiber diet or high-grain diet that they recommend, and they actually were shown to do worse. And to be honest, this was not decreased carbohydrates to ketogenic levels. This was like drop carbohydrates by like 25 grams. It was nothing. That's like a half a bagel, right? But interestingly, if you were IGF-1 positive and did not decrease your carbohydrates, that hazard ratio was over 5. Significantly different. And I will tell you that we don't actually test insulin receptors or insulin-like growth factor receptors on tumors. So we don't tell a patient, oh, you had so many receptors, like really you need to do this. So that's not even looked at. So I just pretend everybody has high everything, right? So now, because I'm going to go a little bit out of my area of expertise, even though I still see other cancer patients, I rarely see. These are usually, and I'll give my plug for a support group that I actually run. So for just probably coming on close to 2.5 years, I have been, more vocal trying to get the word out to patients that aren't necessarily my own. And so I do a monthly support group for ketogenic diet, low carb eating, but I include a lot of science. So anytime a new paper comes out about cancer, a lot of times patients have questions, the usual cholesterol question or whatever. So we'll do education sessions on whatever people are asking about, and we do this once a month. So every second Wednesday at 6 p.m. If anybody's interested, let me know. I'll give you the info. But it's a greatly attended class, but I do have patients who have colon cancer, head and neck cancer, brain tumors that come, and so I try to show science that relates to everybody, and so I'll go through a few of these non-breast cancer related slides. But so this is in stage 3 colon cancer. This was a group of patients who got chemotherapy for their disease, and what they found was that those patients who had the highest insulinogenic diet, so unfortunately all they did was the diet summary, but then they tried to figure out how many carbohydrates were they eating, how was this a high glycemic index diet, and they found that, and I know it probably doesn't project great, but each line basically is a lower or a higher and higher insulinogenic diet, and none of these were even close to a ketogenic diet. So, where might that be if we could get even lower carbohydrate? Same thing with survival. Way worse overall survival the higher that insulinogenic diet was. Dr. Colin Champ and his group looked at lung cancer patients. So these were non-small cell lung cancer patients. These patients were all getting chemotherapy and radiation therapy concurrently, meaning together at the same time. And what Dr. Champ and his team did was look through the charts and just say, we're going to look at every glucose test that was done during their 6-week course of treatment. And a lot of people, I shouldn't say a lot, all the patients go in and get blood tests done before they get chemotherapy to make sure that their blood counts are okay to get that next dose of chemotherapy. And within that blood test panel, there is always a glucose. I will say the majority, not the majority, many of those blood tests are not done fasting, right? Patients aren't told to fast. You can eat breakfast, come on in, get your blood tested, and then get treatment. But no one ever looks at the glucose. Let me tell you how many glucoses I see through the roof, 175, 150, 100, whatever. So again, some of them are normal. Some people come in fasted. Some people don't need to fast, that they eat a lower carbohydrate diet maybe, or maybe are not as metabolically broken as some of the others. But what he found is only at 130, that if he looked at using 130 as a cutoff, that there was a difference in between patients under 130 and those over 130 as to their risk of recurrence. This did not reach statistical significance, but it is still pretty impressive. And so maybe, hopefully, this will stimulate more work to be done. And then in head and neck cancer, and looking at the carbohydrate intake, again, they looked at glycemic load, total sugar intake. They looked at a lot of different things. I just pulled out the 3 that were most striking. And again, low, medium, and high. And low does not mean ketogenic levels. It just means in that group of patients, they just divided it kind of into 3. But you can see when you increase your carbohydrates, when you increase your total sugar, when you increase your glycemic load, you increase your all-cause mortality, which will include cancer deaths as well as other deaths.